Good morning, everyone. Thank you for taking the time to attend our seminar on Singapore's health history and heritage today. Very glad that all of you could take the time out this morning to come here. So the impetus for this research comes from our desire to build bridges between scientific heat stress management methods and methods seen as traditional. This is especially pertinent for the thermophysiological research undertaken by Prof. Jason Lee's labs in Human Potential TRP and Heat Resilience and Performance Center. So that's why I applied for the NHB research grant in 2024 to investigate this issue from a historical angle. And I thank NHB for affording us this chance to conduct this research. So I'm sure you have heard repeated comments from your elders, such as don't drink cold water. It is bad for your body. Drink warm water. Imagine facing such a challenge on construction sites where workers from China may refuse to consume cold water due to their thermal beliefs and practices deriving from Chinese medicine. What should be done in such circumstances? Would acceding to their demands to consume at least room temperature liquids be appropriate? To explore why such divergences in thermal practices exist, our project traced the historical experiences of heat management among Singapore residents, especially from the biomedical and Chinese medicine perspectives. So we hope to gain insights on divergences in thermal practices to equip us with tools to bridge the differences, which we view as an important craft for getting buy-in for sustainable heat management in a warming Singapore. So before continuing, I seek your indulgence for thanking a few people. Firstly, Jason and Pearl, my boss and project manager, who have been key to supporting me in this grant. Xiao Zhen, I think she's not here, who was a great help for all the administrative processes for this grant. My excellent RA, Yu Ying, whom you'll hear from later, I was able to entrust fully the research and writing for this project. Matthew Tan, an undergraduate from the history department, also volunteered to be an RA for 2 months for this project. And lastly, last two, my friend and collaborator, physician Brandon Yu, whom I've known since primary school. So he opened his clinic for us to recruit Chinese medical physician and patient interviewees. And our friends at Center of Excellence in Soldier Performance, especially Lieutenant Colonel Dr. Surya, head of Soldier Development Branch, also my ex-colleague. He graciously enabled SAF's, allowed us to gain SAF's approval and to access and interview military personnel. So back to the talk. So this talk reports the key findings of our research about the historical heat management experiences of Singapore residents since the start of the 20th century. We asked two main questions. Firstly, what is the history and heritage of heat health in Singapore? And secondly, how can the intellectual and cultural divergences in Singapore's heat health practices and beliefs be bridged? I covered the first question, emphasizing history, while Yu Ying's talk later will cover the second, stressing heritage. So some key definitions for this talk. So heat health refers to the effects of environmental heat stress on human health and the health experiences emerging from heat stress, such as practices employed to build heat resilience. And the history of heat health refers to trying to understand past narratives about these experiences and relate them to the present. So that's how I'll be framing these two concepts, these two ideas today. Regarding methods, extensive digital and physical archival research was conducted where we examined sources from various newspaper databases and archives, including Newspaper SG and collections in various libraries, concentrating on sources from the start of the 20th century. To gain deeper biomedical and Chinese medicine perspectives on Singapore's history and heritage of heat health, we conducted 20 oral history interviews with military personnel and Chinese medicine patients. So the SAF has been a forerunner in the use of biomedicine for heat management in Singapore. Hence, we targeted them because it was appropriate to recruit interviewees through them for this purpose. So accordingly, we highlight three arguments from our findings. First, parallel development. So while biomedicine and Chinese medicine, or CM, share a history of managing heat health, they evolved as distinct but connected traditions or strains that were primarily shaped by their own developments. Second, power and popularity. Although governments officially prioritize biomedicine for institutional sectors like the military, CM remained the dominant choice for the general public, who integrated its practices into their daily diets and routines. And third, grassroots independence. Unlike other areas of healthcare where CM was forced to play a secondary role to biomedicine, heat management remained independent and grassroots driven, allowing CM to retain its unique influence without conforming to biomedical standards. So due to time constraints, I focus more on the first argument of parallel development, although elements of the other two arguments will emerge. Our research traces Singapore's heat health history through 4 periods, ranging from early modernization since the 1900s to the current era of regulation, to show how biomedical and CM traditions have both competed and coexisted. And the rest of the presentation is structured according to these 4 periods. For each period, I introduce both the broad heat health and biomedical CM relationship as the main context. Then I delve into the developments of the biomedical and CM heat health strains. So that will be the structure. Okay, the context for the first period. So the first half of the 20th century saw the introduction of electric fans and air cons in elite spaces. By contrast, for many Chinese residents, herbal cooling tea or liang cha was popularly regarded as a remedy for illnesses and relieving heat stress. Medically, in terms of heat health, this was also a transition period. And so we call this first period from 1905 to 45 modernizing heat health discourses, as we find that both biomedical and CM practitioners engage in updating their heat health knowledge to be in line with contemporary scientific standards. Importantly, CM physicians actively compared their methods with biomedical heat health concepts to bolster their credibility and to build intellectual bridges between the two traditions. So such actions from the CM physicians occurred because of the 1905 Medical Registration Ordinance and the subsequent Poisons Bill, which formally established biomedicine as Singapore's only state-endorsed system, legally subordinating CM as an unofficial quote-unquote native practice. So despite this inferior legal status, the colonial government afforded CM significant latitude, as evidenced by softened regulations that allowed licensing based on reputation rather than getting them to take biomedical exams. So this flexibility was a pragmatic necessity, allowing CM to remain the primary accessible provider of healthcare for the grassroots, even amidst public outcries regarding the lack of universal biomedical standards. But this legal subordination had an impact on CM's status. And so in response to, give me a moment, I lost my page. In response, Singapore CM practitioners worked to boost their credibility by publishing medical journals which featured comparative writings on CM and biomedicine to illustrate the compatibilities that could exist between the two traditions. And they also formed a professional union to standardize their practice. So as such, we observe that the biomedical and CM heat health strains developed in parallel during this period. In the early 20th century, colonial biomedicine began transitioning from viewing the tropics negatively as a deleterious environment for Europeans towards a more scientific understanding of human thermal adaptability. So Dr. W.J. Simpson's influential manual, The Maintenance of Health in the Tropics, illustrated this shift, blending 19th century environmental precautions with emerging physiological research on sweating mechanisms and its cooling effects. So his work modernized older colonial strategies, such as advocating for light diets, tepid baths, and specific hydration habits. And he also provided popular scientific explanations that frame heat management as a biological process, moving away from what was called environmental medicine. So ultimately, Simpson's guidance reflected a growing optimism that through organized cooling regimes and proper acclimatization, the European body could successfully thrive in Singapore's tropical climate. So while the English press provided extensive instructions for Europeans struggling with heat, similar advice was absent from the Chinese press, probably because Singapore's tropical weather was already familiar to southern Chinese immigrants. So for centuries, CM had already established a sophisticated framework viewing heat as one of its quote-unquote 6 evils, classifying heat-related illnesses from mild fatigue to fatal heat stroke under categories like 中暑, which is similar to heat stroke. Then there's also 热病, 温病, referring more to having fevers. And they also employed heat management remedies such as herbal soups, avoidance of cold drinks, and promotion of emergency cooling by placing heat-injured individuals under the shade. In Singapore, a process of localizing this framework occurred in the first half of the 20th century. So Tong Chai Medical Institution, one of the oldest CM institutions in Singapore, originally based its examinations for practitioners on classical Chinese texts. But the local practitioners sparked a vigorous debate by arguing that these ancient theories must be localized to suit Singapore's unique tropical environment, which lacks 4 seasons. And so this push for relevance shaped the careers of prominent physicians such as Ong Wei King, Lim Pei Kai, and Lim Keng Ching, all of whom rose to leadership through these exams, and they made significant contributions to the understanding of heat-related illnesses in Singapore. And with CM being legally subordinated, these physicians combined the process of learning from biomedicine to elevate the credibility of their tropical heat health treatments. So, for instance, Ong Wei King, a foundational figure in Singapore's CM community, authored a landmark 1930 treatise, Discourse on Summer Heat and Dryness in Singapore, which adapted classical theories to the local reality of quote-unquote perpetual summer. He pioneered a diagnostic approach that moved beyond generic cooling herbs, instead tailoring treatments to a patient's specific constitution. So he prescribing cooling formulas for people with quote-unquote strong young constitutions and using warming herbs to restore those with quote-unquote deficient young constitutions. Beyond herbal medicine, Ong identified modern lifestyle risks that remain relevant today, specifically warning that the habit of consuming ice drinks and constantly staying indoors to avoid heat, all this a precursor to what is called air-conditioned sickness, could paradoxically cause internal type cold illnesses. Lim Keng Ching, on the other hand, demonstrated creative engagement with biomedicine by adapting the concept of physical cooling. He used ice beds to create this innovative banana leaf and duckweed bed concept. They are basically like leaves and herbs for treating severe heat-related illnesses. So the banana leaf and duckweed bed was a physical cooling therapy that adapted the biomedically related concept of ice beds or ice for cooling the body into a CM framework, using the cold pharmacological nature of these plants to simultaneously draw out trapped heat and seep cooling properties into the body. So by replacing complex acupuncture protocols with these methods, Lim showcased how CM practitioners use a biomedical lens to modernize their practice and develop experimental therapies rooted in traditional pharmacology. Okay, the second view. So the parallel development of the two heat health strains continued during the mid-40s to 60s, along with the unilateral learning of biomedicine from CM, the CM heat health strain. And this occurred during a time where there was an embrace of modern conveniences like availability of ice in the households, aircon workspaces, and new commercial products that made heat management a pleasurable consumption experience. Also, in response to the institutional dominance of biomedicine and growing public concerns over the lack of regulation, the CM community in Singapore launched a scientific modernization movement to prove their practice was a systematic and credible discipline. Leading this reform was Wu Ruifu, the man circled in red, an influential physician who arrived in Singapore in 1930. So together with his other physicians, they established the Singapore Chinese Physicians Association, SCPA, in 1946 to promote Chinese medical research, and the association eventually took on a regulatory role of CM. Through SCPA, Wu led scholarly and clinical efforts to bridge both CM and biomedicine. So he championed the scientific modernization of CM, reframing core practices like as systematic science, such as by equating the traditional four examinations technique like the pulse examination with the rigor of observations and clinical trials. And scientific modernization also extended to his two-step plan, where he sought to institutionalize the deep study of medical classics alongside modern chemistry and physics, and position CM as a complementary system alongside biomedicine. And this philosophy was carried forward by his disciples, Chan Sim Wai, who through the Singapore College of Traditional Chinese Medicine, which Wu also helped to establish. And this became a key school in training CM physicians since the 1970s. So, for the biomedical heat health strain in this period, the view of shifted from a deleterious view to a view that looked at heat as a factor affecting thermal comfort and work performance for humans, so closer to our view of heat today for physiology. So this can be seen through the Royal Naval Tropical Research Unit, TRU, established in Singapore by the Admiralty and Medical Research Council of Great Britain after World War II in 1948. The TRU can be seen as a precursor to subsequent military and university-based thermophysiological research units in independent Singapore, such as the Defence Medical and Environmental Research Institute under DSO, and currently also HRPC. So the TRU use advanced climatic chambers to transform heat health research into a precise, data-driven science focused on human safety and work efficiency. By conducting comparative studies on Chinese, Malay, Indian, and European participants, the TRU demonstrated that thermal comfort and physiological reactions to heat were largely similar across acclimatized European men and women and Asian men and women, and thereby debunking some colonial myths of racial susceptibility there. Their research also championed practical interventions like hydration, specifically recommending cool water around 21 degrees to lower body temperature, and also encouraging higher fluid intake. Unfortunately, they closed down after a few years and their influence didn't spread beyond the university. The Chinese medicine community under Wu Ruifu's leadership proactively localized their practice to keep up with scientific modernization by shifting the focus towards what they call quote-unquote damp heat syndromes, referring to the constantly hot, humid weather alternating between sun and rain in Singapore, causing people to be predisposed to conditions like sluggish pulse, constipation, and diarrhea. They argued that Singapore's constant tropical climate required different considerations than China's four seasons. So, for example, Wu used this localizing approach to correct this local illness called Maltan, which Maltan was used to explain illnesses arising from hot, humid environmental conditions. But Maltan wasn't found in classical texts. So Wu corrected and reinterpreted Maltan as a treatable damp heat condition, and he established an effective cure using classical formulas like Bai Hu Tang. To modernize the field, Wu also integrated biomedical theories into his scholarly works, explaining heat through metabolism, microorganisms, and thermoregulation, while grounding his diagnosis in traditional CM pulse and tongue examination. Interestingly, he also acknowledged the superiority of biomedical methods in treating heat injuries in critical situations, and advised using biomedicine as the main method for emergency situations. And this intellectual bridge building was furthered by his disciples. For example, Cheng Chi An, he interpreted CM concepts like greater yang and protective qi through the thermoregulatory system, And in particular, he argued for a closer correlation between biomedical and CM heat health notions, proposing that an increase in body temperature signified heat, and while a decline indicated cold, grounding CM yin-yang concepts in physiological processes. Ultimately, while the CM community integrated biomedical subjects like anatomy and physiology into their institutions, they maintained therapeutic autonomy by applying flexible herbal prescriptions tailored to local circumstances and individuals. Okay, the third period. So the first 30 years of Singapore's nationhood from 65 to 93 witnessed an exchange of ideas between the biomedical and CM health strains as they converge on some pragmatic solutions while continuing to differ on theoretical frameworks and certain practices. So with compulsory military service after 65, the SCM addressed a rising type of exertional heat injuries among NS men by implementing scientific prevention and treatment strategies like the wet bulb globe temperature WBGT index and the body cooling unit ECU. And there was also the rapid urbanization, the modernization of urban life, which witnessed the further popularization of cooling technologies like refrigerators and air cons. And this also then led CM practitioners to warn of aircon sickness or the qiping. So regarding the biomedical CM relations, this period saw the first formal dialogues between the two medical traditions, including a government-supported comparative study led by Dr. Gui, and also a surge in biomedical interest in acupuncture for anesthesia, that led to the opening of a pain management center at Singapore General Hospital. However, there was also friction. Most notably, in 1981, there was a dispute on Huang Lian, a herb, where the Ministry of Health banned the herb, and there were also dismissive comments that were passed. And this highlighted a deep-seated biomedical sense of superiority and refusal to acknowledge CM's holistic framework. So what these developments imply for the relationship between both heat health strains? So a significant divergence remained regarding water temperature. So while biomedical practitioners advise drinking cold fluids for faster stomach emptying and comfort, the CM community reinforced a long-standing principle against cold water, viewing it as a pathogenic factor disrupting internal balance. But despite disagreements, mutual learning occurred, and the first interesting example was the commercialization of the beverage market, where commercial drink brands like Yo's and F&N, that's why we provided the package drinks today, acknowledged the popular culture of herbal drinks in Singapore, incorporating their own lines of herbal drinks alongside science-backed isotonic drinks like 100 Plus. English language newspapers also began to engage with the CM concepts of yin, yang, and heaty versus cooling foods, signaling an attempt to bridge the gap for English-educated Singaporeans. However, this learning was often flawed because, for example, biomedical observers simplified cooling properties to mere hydration, attributing effects of cucumber and herbal tea solely to their water content, and dismissed traditional explanations as quote-unquote myths. For the Chinese medicine side, the SCPA proposed integrative heat injury treatments that incorporated CM and biomedical angles, highlighting their continued learning from biomedicine. So, for instance, CM Wu Chang came up with an emergency treatment for heat-related fainting, which combined CM methods such as pricking specific acupuncture points on the fingers and face to release blood, and administering cooling herbs like antelope horn water, with the biomedical practice of applying ice packs on a patient's forehead. And so this integrated approach focused on both restoring consciousness to traditional sensory stimulation and using cooling to lower body temperature during an emergency. Okay, finally moving to our fourth period, from 94 to the present. So we observed the parallel development of the two health strains, but we observed them in the sense that they led to distinct emphasis in this period. So while the biomedical strain focused on hyperthermia in this period, the CM strain moved towards focusing on preventing internal imbalance. So focus on hyperthermia became a pressing concern for the biomedical strain because of two developments: the increasing unacceptability of military injuries and deaths among the Singapore public, and rising temperatures due to global warming and the urban heat island effect. Interestingly, in this period, we don't observe much mutual learning between the two heat health strains. Even though on the level of the broad biomedical CM relationship, significant steps were taken to institutionalize the relationship to make CM the leading complementary medicine, medical tradition to biomedicine. So this was executed through the formation of the TCM Practitioners Board in 2000, which introduced an official accreditation process for physicians, and the establishment of a degree program in NTU in 2005. And through government regulation, the relationship between the two medical communities evolved from skepticism towards some kind of informed acceptance, allowing practices like acupuncture for pain management to be integrated into public hospitals. Okay. As mentioned, hypothermia became a core focus of the biomedical heat health strain in this period. And since the 1980s, a number of heat management strategies through biomedical research have been implemented in the military, such as safety regulations, which stress progressive training to lead to heat acclimatization, work rest cycles for strenuous activities, and I think a lot of the guys can remember water parades. Yeah. And also emergency treatment for heat injuries through the use of the DCU for rapid cooling. So another strategy was the WBGT index to guide heat stress management of military and outdoor workers, a method requiring sophisticated temperature sensors and an index to stratify WBGT levels for different heat stress measures. So in this period, we observe actually the extension of some of these strategies from the military to the public. So prior to the 2010s, the SAF relied on WBGT readings from heat stress monitors placed at just 4 medical centers. But a significant development occurred in 2014 when the SAF introduced portable heat stress monitors that allowed for localized on-site measurements, and they linked it to a new 5-level WBGT and work rest cycle index, which allowed more granularity and also a lot more on-the-ground decision-making to happen. And measures were belatedly extended to the outdoor workforce, who were mostly foreign origin, in the 2000s, in response to heat injury incidences among them. So progressive steps were taken from 2010 to 20 to the first comprehensive workplace safety and health guidelines on managing heat stress. So key concepts like heat acclimatization were formalized, and structured programs were prescribed for new workers to gradually increase their exposure to heat. And these measures were integrated into a WBGT index where employers became legally required to implement specific measures like dictating water intake and scheduling modifications based on WBGT stratifications. And since then, the WBGT index has been further extended to the public in 2023 with specifically crafted measures for the public, making guidance easy for a non-military audience. So the biomedical heat health strain's emphasis on hypothermia in this period meant that its focus solidified. In this period, CM strategically ceded the domain of acute crisis care to biomedicine, officially advising the public to prioritize biomedical emergency responses for life-threatening conditions like heat stroke. However, in terms of preventive strategies, both heat health strains converge in a complementary direction. So biomedicine focused on upgrading the body's efficiency through heat acclimatization protocols and hydration regimes, whereas CM focused on cultivating long-term constitutional resilience through culturally embedded lifestyle habits. So for CM, these strategies were promoted through food-based remedies and lifestyle advice, often circulated through channels like Chinese language media and family traditions. And the CM preventive toolkit emphasized basically clearing internal heat or dispelling dampness through specific herbal teas, which were recommended in this media, and alongside holistic lifestyle advice such as limiting air conditioning, adequate sleep, and gentle exercise to restore the body's self-regulation. So ultimately, because biomedicine treats the body as a biological machine that can be trained to adapt to external forces, while CM treats the body as an internal ecosystem to be kept in balance, their recommendations rarely conflicted, allowing individuals to use both systems to manage the tropical heat. So in conclusion, we have illustrated the parallel development of biomedical and CM heat health strains from the early 20th century to the present day, and we've contextualized it within the broad biomedical CM relationship. And we have shown for the first 60 to 70 years, there was a lot of unilateral learning from CM and not much learning from biomedicine. But from the 1990s onwards, mutual learning actually occurred. And then in the present day, we see a strengthening emphasis or two distinct emphases between both heat health strains. So in summary, the coexistence of both systems is defined by their distinct conceptualizations of heat. And we argue that this difference allows for a parallel, non-conflicting relationship between biomedicine and CM, where biomedicine can provide scientific tools for acute risk assessment and emergency management, while CM can offer preventive lifestyle framework to build long-term heat resilience, which can be cohered with biomedical preventive measures like heat acclimatization. And so recognizing these two traditions target different dimensions of health would highlight significant potential for closer integration of these heat health traditions in the future. Thank you very much.